We're going to talk about different types of radiation, but before we do, I just wanted to give some context to some certain terms that we see in prostate cancer clinical trials, and I think it's important for patients to recognize when we hear these terms. Different clinical trials are looking at different qualitative outcomes. So there's overall survival, so how long did someone live? There's PSA progression, so if you had a treatment, how long does it take for your PSA to progress? And really what we all want, and the most important thing that we talk about, and this is where overall survival comes in, is cure rates. And it's kind of interesting because we compare radiations oftentimes, and it's effective, and a lot of people compare it against surgery. You're looking at cure rates, so the idea of being cured, but another thing that we have to look at is what they call QOL, quality of life. And so all of these factors really need to come into play when you're making a decision about a treatment. And so in today's clinical trial, it's from ASCO GU 2025, it's abstract 388, and it's talking about EBRT, so a type of radiation, and they're comparing it to hormone therapy. So before we get on to our bigger conversation of comparing radiation therapies, let's talk about this abstract for a minute. So can you talk about kind of the outcomes and what they were looking at and really what the goal was of the clinical trial?
So it came from Kaiser. I think it's a West Coast HMO that does a large volume. And a guy named Barry Goy, who's been a radiation therapist, a very respected one at Kaiser for some time, sifted through their information and looked at hundreds and hundreds of patients that had beam radiation at Kaiser with or without 6 months of hormone therapy for what we call intermediate risk prostate cancer. So the type of prostate cancer that does need treatment, but not the worst type. What was useful about this report is that it gave 10 and greater year outcomes. We know the prostate cancer story plays out slowly, and to really define how well people do, you need a lot of time to see whether they stay cured or not. The thing that's confusing in the cancer world is that with prostate cancer, if it's treated properly, the mortality rates are very low. If it's not treated optimally, if you don't get cured, it can be a real headache to have the cancer come back again, and then to try and treat a situation the prostate's already been treated. It's more fragile now, it's more difficult to treat. You may have to go on hormone therapy. There are a lot of very negative things that happen, not in the sense of someone dying of the disease, but the impact of the cancer coming back and degrading a person's quality of life, the QOL that you talked about. The not too surprising fact from this report was that after 10 years, about half of the men had had their cancer relapse, even though they were treated with state-of-the-art beam radiation with or without 6 months of ancillary hormone therapy. Hormone therapy is thought to enhance cure rates and improve the anti-cancer effect of the radiation. These patients were treated with appropriate state-of-the-art therapy. Only half stayed cured. Pretty disappointing. Not that surprising to myself, who's looked at other studies of similar structure and that also report much higher relapse rates than you would typically be comfortable. Well, one would hope if you go through this exotic radiation and hormone treatment that looking at cure rates hopefully in the 80 to 90+% range, and to have only 50% of the men stay cured is disappointing. I think that this has led us at the PCRI many times to talk about looking toward a higher dose type of radiation, such as brachytherapy, as a more definitive treatment and leading to higher durable cure rates than what we're getting with beam radiation.
So getting into the why of why these men failed, I know you're talking about brachytherapy and the higher dosage. Is it that the EBRT or the IMRT or any of these types of beam radiations are lower dose and they're not being as impactful at killing the cancer, or is it that they're missing cancer?
No, they're not missing cancer. The reality is that when you beam radiation through normal tissue, from outside into the prostate, and where the beams cross, that's where they get the really high dose. But there is a limit, a safe limit, and there have been studies, pushing that limit higher and higher to see what the human body can tolerate. And so when they arrive at that limit, it's capped at that level. Otherwise, you're going to run into unacceptable toxicity. The reality is that due to the limitations of the technology and the physics of the situation, when the radiation has to be beamed through normal tissue, the doctors that are giving beam radiation can't safely deliver the same intensity of radiation that a brachytherapist can, someone who puts seed radiation right in the prostate. They don't have to let the radiation pass through normal tissue to hit the target. And yes, it's basically an inadequate dose of radiation. Why would this be accepted? And the answer is, well, it's been sort of the pro forma for a long time. The difficulties with the cancer coming back have been sort of a reality in the prostate cancer world with both surgery and radiation for many years. The, quote, relapse may not occur for many years down in the future. And there's just a lot of momentum for treating people in this fashion. It's became accepted as a standard approach. Outside the United States, it's different. Usage of brachytherapy is continually rising for the obvious reasons that statistical outcomes are better. Here in the United States, it's sort of business as usual. Suboptimal dose is the problem.
Before I get to my next question, I just wanted to remind you that this September we're having an in-person prostate cancer patients and caregivers conference, and it's a great way to get your questions answered by world-renowned experts. You can learn more at pcri.org/conference. Now, don't forget to click that subscribe button and share these videos with other people. It's a great way to support the work we do, and if you would like to support us financially, you can do so at pcri.org/donate. Now back to my conversation with Dr. Shules. Well, it's kind of interesting because in the study they're talking about patients who were treated with or without 6 months of hormone therapy. Now, the interesting thing about it is, so hormone therapy is a systemic treatment where it goes through your blood and it's supposed to be cleaning out, micrometastasis that could pop up in the body. So you're getting the direct dosage of the radiation to the prostate, into the prostate bed and surrounding areas, lymph nodes, but then you're also getting the systemic effect. The fact that these men also progressed even with the hormone therapy is quite interesting. Why do you think that was?
More and more we're finding, as men are being staged more accurately, that very few of these men have micrometastatic disease. So the hormone therapy really isn't eradicating micrometastasis and thus enhancing cure rates. What it does do is synergize with the suboptimal dose of radiation inside the prostate, and working together with the radiation, you augment the cure rate or the eradication of the cancer in the prostate gland itself. This is sometimes talked about as a reason to do surgery. Well, at least you don't have to do hormone therapy to get local control, to eradicate the tumor itself. I don't know, people aren't aware of the fact that there is no such thing as a radio-resistant tumor. If you give a big enough dose of radiation, you can kill any prostate cancer. But due to the limitations of beam radiation, and when men are getting these forms of beam radiation, they are getting suboptimal radiation in many cases, not all cases. Some men do get cured, about half in the study that you're reporting from. But the cure rates are, twice as good in the men that get an adequate dose of radiation through brachytherapy.
So when we talk about quality of life, if you think about radiation side effects, you have short-term side effects and long-term side effects. And I think when it also comes to hormone therapy, we see a lot of doctors just put patients on hormone therapy automatically, even when they are getting localized, treatment to the prostate. And so in comparison with brachytherapy, are we talking about brachytherapy